So my goal of this talk, it's called Oncologic Emergencies. It is not to bog you down with weird genes and drugs and letters that are supposed to mean chemo that don't make sense. That is not my goal. My goal is really to get through a few onc emergencies that if in the middle of the night they happen, you know what to do. Because that's really the scary stuff. During the day, you always have support. But at night, you're like, oh, what am I supposed to do? Everyone, can you hear me okay? Okay. So let's start with APL. So this can be really scary when patients present. It is a subset of acute myeloid leukemia, which I'm sure most of you have seen at least once or twice, and it refers to neoplasms involving the myeloid lineage. APL is a distinct variant of AML. It's treated differently. It should be thought of differently. It was first classified way back when as M3 in the FAB classification system, and you'll often hear attendings still refer to it as such, M3. It's currently classified as APML, with the translocation 1517, leading to the PML-RARA translocation by the World Health Organization classification system. It accounts for about 5 to 20% of cases of AML. Though if you've been on the floor and seen this, you would think that it's more, because we have a decent amount of them here. Age distribution of this disease is different than AML. It increases during the second decade of life and kind of plateaus in early adulthood and actually decreases after the age of 60. Which is very different than the other AMLs. It does not vary by gender whatsoever. And APL can be a de novo disease, but it can also occur after cytotoxic therapies for other diseases, especially in association with topoisomerase II inhibitors, such as etoposide and doxorubicin, or even after radiation. It's also been observed in patients with MS that have received mitoxantrone, which is another topo II inhibitor. And it can transform from MDS. Now, what I just said is not specific to APL. That can go to all the AMLs, including APL. The scary thing about this is it is very vague. There's really not a classifying or characteristic thing that happens to a patient. Typically, it's something related to the results of pancytopenia. And it can be weakness, fatigue, it can be infections, it can be hemorrhagic findings. It's rather unlikely to see APML or any AML for that case with normal cell lines. They typically all have some sort of celling that's down. Typically, it's more than one. Unique to APL versus AML, so just to clarify again, AML and APML are very different, though they're all under the umbrella of AML. I might be using APL a lot, but that still means APML, okay? So unique to this is presentation with bleeding secondary to DIC. APL itself, if you catch it in the very beginning, which we never do, is usually not a rapidly proliferative acute leukemia. The problem is by the time they actually have symptoms or present to you, it can actually be a life-threatening emergency. Even if the flow shows only a small amount of APL cells, or the diff only shows a small amount of blast cells in the blood, it does not mean that there's not a huge amount of malignant cells in the marrow that are provoking a severe coagulopathy. So what is this coagulopathy? It involves both clotting and bleeding, so DIC and hyperfibrinolysis. So it involves both. They can bleed just as much as they can clot. And sometimes having low platelet counts does not mean that they won't clot, and normal platelet counts does not mean that they won't bleed. It's often present at the diagnosis of the initiation of therapy or just on presentation. There have been some anecdotal people that have said that they've never seen APL with normal coag. I've not been around long enough to say that that's true or not, but some very smart people have said that that's true. So with that being said, it does constitute a medical emergency. It can cause pulmonary or cerebrovascular hemorrhages in up to 40% of patients. And about 10 to 20% die of early hemorrhagic death. And I'll talk about this a little bit later, but that typically happens in the first 24 to 72 hours. Those are the critical hours. The mechanism of the coagulopathy in APL is not entirely understood. It is thought that tissue factor forms a complex with factor 7 in order to activate 10 and 9. The rearranged RARA in APL activates the tissue factor promoter and increases its expression in leukemic cells. Death of APL cells is actually by etosis. So it's not apoptosis, it's not necrosis. And basically what that means, this was discovered, don't quote me, but recently. It's not in the textbooks of the 1950s, 60s, 70s. But etosis basically is recently described. It's a death occurring by what they used to think was just by neutrophils. So the neutrophils would kind of release this extracellular lattice of DNA and chromatin and all these different things to kind of create a web and kill the leukemic cells. So it used to be called netosis, N-E-T-O-S-I-S. It has now been recently found that other cells can do this as well, eosinophils, basophils, and whatnot. So it's just called etosis. But it's basically the cells mix and extrude their DNA to create a web, in a way, to kill the other cells, the bad cells. This ends up damaging endothelial cells and converts them to a procoagulant phenotype. The induction of tumor cell differentiation. So what does that mean? Myeloid cells are immature cells. Differentiation means you are pushing them to become more mature. More mature cells behave better. Think of it as like toddlers versus, 35-year-olds. I was going to go 20-year-olds, but sometimes 20-year-olds don't behave either. So think of it as like very early cells versus older cells. The younger cells don't behave. They bleed, they clot, they do all these different things. So tumor cell differentiation is to push these cells to become more mature. That in APML is done with retinoic acid. If you do this, this can rapidly lead to the improvement of the coagulopathy that patients can present with, okay? In the meantime, though, that coagulopathy can get worse. But again, when we talk about differentiation, that just means pushing them to be more mature cells and behave better. Pathology and genetics. So this is the typical blast cell that we always see on boards or in USMLE step, whatever. It'll be on internal medicine boards. They're large. They're myeloid precursors. They can have different morphology. They always have a high nucleus to cytoplasmin ratio, fine chromatin, and a prominent nucleoli. So if you're looking under the microscope, you can often see the nucleoli, and the cells, the cytoplasm is not as much as you would expect to see on a normal-looking cell, and I'll show a picture in a second. The translocation is of 1517. That is the characteristic definition translocation for APML, and that creates the PML-RARA gene. It's the presence of a reciprocal translocation between the long arms of chromosomes 15 and 17, creating this fusion gene. The RARA is the retinoic acid receptor alpha. And the only reason I say that is you can, and you might see on your boards, they won't call it RARA. They'll call it this retinoic acid receptor alpha. And really, you all have heard of RARA, but you might not have heard of that. So just keep that in mind. And then the PML, which is the promyelocytic leukemia gene as well, translocated to form that gene. So this is an APL blast cell. This is an Auer rod. This should be burned into your brains for sure because it'll pop up on some exam at some point in your lifetime if you haven't already seen it. So it's that little tiny rod there that the arrow is pointing to. So the scary part about the diagnosis, the best thing is to suspect this early. And it's suspected by the characteristic morphology of the cells, seen under the microscope, the immunophenotype, which I'm not going to go through because I don't think that's important for what you guys need to know right now, and the presence of a coagulopathy. It takes a high index of suspicion because the diagnosis is confirmed by the PML-RARA gene or fusion gene. And you can send up the molecular and the FISH analysis to look for it, and that is what we do when we suspect it. But unfortunately, that typically does not come back quickly. And sometimes it can even be a day or two. So in that day or two, circling back to what I said earlier about those first 24 to 72 hours, those are the moments that the hemorrhagic death, if it's going to happen, happens, typically. So if you're realizing we're trying to treat and control a disease before we know what it is, and that's what makes it scary, which is why we need the high index of suspicion. And obviously we do a bone marrow as soon as possible and send up those studies as well, but again, they're not done stat. So untreated, median survival is about less than a month, and it's typically from uncontrolled bleeding and clotting. With treatment, it is actually one of the highest cures for myeloid leukemias. If you're younger than 30 and your initial white count is less than 10,000, you have a superior event-free survival. Age greater than 60 is not a poor predictor. So sometimes when we get into the other AMLs, We are forced to give them chemotherapy. Age being greater than 60, they don't always do as well. What is nice about APML is we don't always have to give chemo, which I'll get into in a second. So the probabilities of a 3-year relapse-free survival, they broke them down into 3 different categories, and it was all based on white counts and platelets. So low risk, less than 10,000 white count, platelets greater than 40,000, relapse-free survival 98%. High risk, greater than 10,000 white cells, relapse-free survival 70%. It has been proposed that these actually can be broken down into 2 groups based entirely on the white count, meaning the platelet count is not necessary to distinguish between the low and intermediate risk when these patients are treated with ATO. What is ATO? ATO is arsenic. So probably about, I was a first-year fellow, so about 4 or 5 years ago, there was an article that came out in the New England Journal of Medicine that talked about treating APML with ATRA and arsenic. Going back even further, we knew that ATRA, all trans-retinoic acid, is a treatment for APML because it pushes those immature cells to become more mature and behave appropriately. What we used to do was mix it with chemotherapy at times. What this article found was that arsenic and ATRA together actually were better in the low and intermediate risk APML than ATRA and chemo. So this differentiation between low risk, intermediate risk, and high risk is actually very important because it changes what we do. And chemo sucks. It's basically poison you're putting into the veins, and it bothers every organ imaginable. So any way that you can avoid chemotherapy, granted it's with arsenic, and you might say that, well, that's not good either, and it's not, but it's actually better than giving chemotherapy. So this differentiation between low and intermediate and high is very important because we know in low and intermediate that ATO and ATRA is a better treatment regimen than ATRA and chemo. High risk, we don't have the data yet, and typically most people will give chemo and ATRA if they can tolerate it. When to suspect it and what to do. As I've said a few times now, it requires a very high index of suspicion because the symptoms are so nonspecific. Easy bruising, high white count, low white count, pancytopenia, or at least one of the cell lines down, is something that should at least cross your mind. It might not be number 1 on your differential, it might be the last, but always keep it in the back of your mind somewhere. Always get a CBC with diff. I would venture to say that I think a CBC without diff is almost worthless. Here's why. A high white count, you want to know what cells are making that up. Are they bands? Are they neutrophils? Are they lymphocytes? When you have a low white count, what's making that up? What's lacking? What is driving the white count to be lower? And then conversely, let's say you have a stone cold normal white count. But let's say your lymphocytes are through the roof and your eosinophils are very low. You might still have a normal white count, but that doesn't tell you anything about what's actually going on, and you might miss it. So don't get a CBC without diff. It's always important to have it. If you're suspecting this at all, always get the coag. Always, always, always get the coags. Uric acid, phos, CMP, and MAG. Start fluids. Call us immediately. If there's ever a concern for leukemia, any AML or any APML, call us. They're all emergencies, but APML, those first 3 days are critical, so call us. Don't worry about what time it is, just call us. And if there's ever a suspicion, we always start ATRA. Don't wait to call us, mostly because ATRA itself is not that dangerous of a medication. It's relatively harmless. So it is 100% better to suspect the diagnosis, call us. We start ATRA and all of us be wrong than to miss this diagnosis, because those first 24, 48, 72 hours can make the difference between life and death. This kind of leads us right into tumor lysis syndrome. So it's caused by cell, first of all, any questions on APML? Or I'll answer them at the end if anyone has any. Okay, tumor lysis. So it's caused by cell death and the release of large amounts of potassium, phosphorus, nucleic acids, uric acid into the circulation. An increase in uric acid results in the precipitation of uric acid in the renal tubules. It can cause renal vasoconstriction and inflammation, resulting in AKI. Hyperphosphatemia with calcium phosphate can also deposit into the renal tubules. Tumor lysis most often occurs after cytotoxic chemotherapy in patients with high-grade lymphomas, particularly Burkitt's, and also in ALL. That being said, it can occur spontaneously. So no chemo is given, patient just has a bad disease, and they can start auto-lysing. And this typically happens in cancers that have a high proliferative rate, as well as a large tumor burden, or ones that are very sensitive to cytotoxic chemotherapy. That includes APML, small cell cancers, high-grade neuroendocrine. And this really relates back to the cell turnover with autolysis or chemo-induced lysis. So what does that mean? When cells turn over quickly, especially in cancer, they can tend to die quickly as well. And that is without any chemotherapy. So that can happen automatically with Burkitt's and some of these other hybrid ones. On top of that, any cancer that has a high proliferative rate or is very sensitive to chemotherapy. So chemo always attacks cells that are, what's the word I'm looking for? Dividing rapidly, right? So cells that are dividing rapidly are going to be very sensitive to chemo. So if there's a lot of those cells and you're giving chemo, they're going to start lysing. And I would venture to say that I wouldn't rule it out for any type of cancer. We always say that solid organs is less. That being said, cancers can transform. So prostate cancer, for example, it typically will not cause autolysis. It won't. But prostate cancer can transform, rarely, into a higher grade small cell based cancer. Small cells can and will lyse. So as a general rule, it's typically not the solid tumor ones that do it, but never rule it out because all cancers can transform into something more aggressive. What is the definition? So uric acid greater than 8, K greater than 6, phos greater than 4.6, calcium less than 7. AKI, and most of the time we look at this is defined within 2 of 4 of these for a 24-hour period. That being said, none of us are sitting there waiting, well, this happened at 12:22 on a Tuesday, and we're going to wait until 12:22 on a Wednesday to treat this. So this is the definition, but I would say I don't think anyone really waits to act on this to wait for this time definition. High-risk ones, so the ones that will do it on their own even without getting chemotherapy. All Burkitt's leukemias, stage 3 and 4 Burkitt lymphomas, all ALLs with a high white count or a high LDH, AML with white counts greater than 100,000. Now that is AML, which is very different than what I was just talking about, APML, because we use the cutoff as 10 there. Stage 3 or 4 lymphoblastic lymphomas, or early stage cancers in the same subgroup with high LDHs. CLL treated with venetoclax, which is a second-line therapy for CLL with a high lymph node burden. T cells, diffuse large B cell, peripheral T cells, transformed lymphoma. So that circles back to what I was saying before. You can have a low-grade lymphoma, but it can transform into something more high-grade, which would be more likely to have and be associated with tumor lysis. What do you do? Anyone that's been in service with me and has had this has probably heard me say this a bazillion times. Fluids. Number one, slam them with fluids. Fluids, 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 and more fluids. And the answer is still fluids, and then more fluids. So that's number one. The treatment for this, I was kind of talking about 2 before. So there's one that's autolysis from just the cancer itself, but then there's the other tumor lysis that happens after we give them chemotherapy and we're anticipating it. They are treated the same. Fluids, number one. The scary part about this is sometimes it can be the presenting symptom in a new cancer diagnosis. So I'm going to sidetrack and tell you a brief story. So I was probably a second-year resident. A lady came in with lower extremity swelling. She had a history of autoimmune hemolytic anemia. Both of her legs were really swollen, and she was also complaining of some weird toe pain or ankle pain or something pain. And a uric acid was sent off looking for gout. Okay, so this is someone that comes in, has a history of autoimmune hemolytic anemia, both legs are totally swollen. She has a little bit of a murmur, her uric acid is high, I think it's like 11 or 12, okay? I was interested in onc, so it piqued my interest, but this was missed for about 24 hours before I saw her. A lot of these cancers can have related autoimmune hemolytic anemia. So underlying Hodgkin's, underlying CLL can have autoimmune hemolytic anemias. So I saw this very high uric acid. I checked an LDH. It was like 12,000 or something ridiculous. I ended up pan scanning her, and the reason her lower extremity was so swollen was because she had lymphadenopathy everywhere, compressing the vasculature. So this was, honestly, it was someone that was interested in cancer, and I happened to see the LDH that was through the roof. But think about how easily that could have been missed. Easily, she had toe pain, she had lower extremity swelling, she had a history of autoimmune hemolytic anemia. They were throwing out things like heart failure was causing this, she had multiple clots, all these different things. And really what it came down to is she had an untreated cancer that was progressing. And the reason she had the autoimmune hemolytic anemia was secondary to the underlying cancer. So I say this as a story because it's stuck in my mind a lot. Anytime I see a high LDH or a high uric acid, I order the other. So if I see a really high LDH, I'm always checking the uric acid. If I see a really high uric acid, it doesn't really make sense, I'm checking an LDH. They are not specific, but they tip you off to start thinking that there could be a huge tumor burden that we are missing. So I would say if you guys see these labs coming across and they don't entirely make sense, order the other one. Because sometimes you will uncover an underlying cancer that otherwise would have been missed. Anyways, back to the talk here. So in terms of fluids, we get this question a lot. All of the cancer patients getting chemo will get volume overloaded at some point. Doesn't matter how young they are, how good their heart is, how good of shape they're in. We give them so many fluids that they all get volume overloaded. If there is a concern for tumor lysis, do not stop fluids. Don't lower the rate. Don't stop them. Give Lasix. This is one time, well, there's probably another one, but this is one major time that you can give fluids and Lasix at the same time. Because the goal is not to get to a certain volume status. It is to keep fluid moving through the kidneys. That is your number one goal. So at all odds, keep the fluids going. If they start having difficulty breathing, start slamming them with Lasix. Now, obviously, there are extremely extenuating circumstances, but in general, you keep the fluids going. Then the question of respirocase and allopurinol always comes up. For the initial management of intermediate risk for tumor lysis, so all those ones that I ran through with you, those are all high risk, so none of those. Intermediate risk for tumor lysis, we can give allopurinol in the pre-treatment setting as long as uric acid levels aren't already elevated. As acutely, allopurinol doesn't really decrease the pre-existing uric acid that's there. For the initial management of patients at high risk for tumor lysis, we do give resveratrol up front, which helps decrease any pre-existing uric acid levels. In an acute and new diagnosis of tumor lysis, so someone that is not anticipating chemo, this is all happening in real time, it's a little bit provider dependent as to what the cutoff is to give resveratrol. I think everyone starts to consider it in an acute setting if the uric acid is greater than 8 and there's evidence of AKI. But pretty generally, if it's over 10, most people are giving it. And we do actually have a protocol here as to a little pathway to go through, which I did ask our pharmacist to get for us, but I didn't get it till this morning. So I will send that out to you guys as well. But that's basically resveratrol and allopurinol. Any questions about there, or I can also answer them at the end. Okay. TTP. Oh, go ahead. Sorry. So that's interesting. Where I came from, we never checked. If we were worried enough that we wanted to give resveratrol, we never checked G6PD. If it was in the middle of the night and it was scary, we just gave it. It has seemed that the culture here is that we always check it first. I don't have a right answer for you. And this is just based on where I came from and what we did. I never checked it. Or if we had time to check it, we would check, but in an acute setting, we wouldn't. Here, I've noticed that they wait. Even if it's in the middle of the night, they'll wait. And you can argue what's right or wrong. I don't think there's any evidence to support one way or the other because it is true. If you have a G6PD deficiency, it can cause problems. And I think there was a case here, I don't know the details of it, years ago that something bad had happened. So I think that's why it's ingrained in the culture here. It is certainly not wrong to do that. My personal preference is if it was in the middle of the night and it was an emergency and we were worried about it and we weren't getting control of the situation, I'd probably give it. But again, that's a little bit provider dependent. Good question, though. So TTP, moving on to another emergency. This isn't really an onc emergency, but it fits in with heme, so I decided to add it in. People suspected to have TTP or another primary TMA syndrome we must focus on trying to distinguish which one is which, because there's other systemic disorders that can present with MAHA and thrombocytopenia. The primary TMA syndromes include TTP, which is the one we all always hear about, Shiga toxin HUS-related TTP, drug-induced, and complement-mediated TMA. These syndromes all require urgent treatment, but the treatment should be directed at what the underlying cause is. They're not all treated the same, and TTP is its own distinct category and has its own distinct treatment plan. TTP can be acquired or hereditary. Acquired usually presents as severe microangiopathic hemolytic anemia and thrombocytopenia in a typically previously healthy individual. Not all patients walk in and are critically ill. It's defined by a severe deficiency of Adams T13 levels in activity, typically less than 10%. It should be noted, though, that not all Adams T13 inhibitors are demonstratable in the available assays in hospitals. Levels should always be sent off before initiating PLEX. So it can be called PEX, it can be called exchange, it can be called PLEX. They're all the same thing. I think in this talk I use mostly PEX, but PLEX, exchange, they're all perfectly fine terms to use. The diagnosis, this is another one, really relies on clinical judgment because the Adams T13 levels typically don't come back for days. And waiting for days in someone that has true TTP is also another life and death situation. Unique among the primary TMA syndromes is that there's actually typically minimal abnormalities in kidney function. So there is AK there, I'm not saying that it's not, but it's not sometimes on the level that we are trained to by the steps in USMLE and whatnot to think that it really is, even though there's often microthrombi deposits into the kidney. Typically the thrombocytopenia is a bit more severe. Abnormalities of the central nervous system, heart, pancreas, thyroid, adrenal, and whatnot can occur. The lungs are typically spared in true TTP. There's no clinical feature that distinguishes TTP. They're, again, very nonspecific. Weakness, fatigue, purpura, GI symptoms. And if I took this part out and I put it into the APML, you wouldn't know the difference. So my point is here that they're all very, very vague symptoms, and there's not one thing you can look for to look for any of these syndromes on a clinical level. It's not one thing. I think we're also all always taught that there's neurological symptoms involved. Not always the case. About a third have none. A third have mild, which are headaches and transient confusion. And then a third have things that are much more severe. I think at least through medical school and residency, you're taught that neurological symptoms are always present. They're not. And oftentimes they're very, very subtle. They rarely have overt bleeding. AKI and low platelets are typically seen. If there's ever a concern, get a smear and call us immediately. So this is an article, it's old, I forget how old, sometime in the 90s came out in Blood. And it basically reviews presenting features of TTP. And yes, it's old, but it's still relevant. So the MAHA and thrombocytopenia were present in 100%. Severe neurosymptoms present in 53%. Minor, 27%. None whatsoever, 20%. Acute renal failure, 5%. Renal insufficiency, 47%, along with normal renal function, 47%. And fever only in about 10%. So I think this is just a nice thing that really, it's the anemia and the thrombocytopenia that should drive you, even though we're taught that it's always the triad of the confusion, neurosymptoms, as well as the AKI. Immediate decisions on where to go. So does this patient need urgent PLEX? Do they need anti-complement therapy? Are there other treatment options available? And basically, if there's a high suspicion for TTP, we pull the trigger and we start them on plasma exchange. If there's a suspicion for complement-mediated TMA, anti-complement therapy is the way to go. High suspicion for other systemic disorders, such as sepsis and whatnot, are treated as you would treat the underlying cause. Among all of the TMAs, TTP is the disorder with the greatest acute mortality, up to 90% in the pre-PLEX era. PLEX is essential for the treatment of TTP. However, the possible benefit of PLEX for other primary TMA syndromes is less clear and therefore less urgent. I'm not saying that you won't see people do it, because sometimes you go through what you think you should be doing, patients not getting better, so we pull the trigger and we start them on exchange as well. But unless it's true TTP, the evidence to support PLEX in those situations is not as strong. A presumptive diagnosis of acquired TTP is also an indication to initiate PLEX therapy. So just to run through a few examples, because it is confusing, because all these diseases are related, but they're kind of on a spectrum. So a patient walks into a primary care office after several days of not feeling well, found to have severe anemia, thrombocytopenia, fragmented cells, but the kidneys are fine. This actually should make you think of TTP, and honestly, we would probably start PLEX exchange in a patient like this. If the history is consistent with a drug-induced TMA, so the calcineurin inhibitors, some of the chemotherapies, and all of a sudden it looks like they're developing a TTP type picture, it actually might be possible to avoid PLEX. Now, we had a case, I think last year, and I forget the presenting symptom, I wasn't on service, but there was someone that they thought that it was gem-induced TTP. So they treated him, they stopped the chemotherapy, and eventually he just wasn't getting better. So the trigger was pulled, and PLEX was given. He got better, but was that necessarily because of the PLEX? Was it time? Who knows? So I'm not saying it's not done, but it might not be the first thing you jump to. Next situation, a pregnant patient has just delivered. There's a rapid development of AKI with anticipated need for dialysis. You should suspect postpartum complement-mediated TMA, and anti-complement treatment should be given. You should not be jumping to PLEX in these patients. I bring this picture up because this is another thing we see in textbooks and on tests. You're expecting to see this beautiful smear with like these schistocytes that are all over the place, and oftentimes it's really not that pretty, and it's much more subtle. So this, as you can see here, there's some helmet cells, there's some large platelets, there's also some microspherocytes. This tells me, looking at the smear, is that there's a hemolytic anemia going on. The platelets are being destroyed because you see the big platelets, that's what the marrow is pumping out. And you see these fragmented cells, which tells you that there's some sort of hemolytic anemia going on. So this is not the picture you would see on a board when you're thinking about TTP, but this might be more so what you see in real life when you should at least start thinking about the diagnosis. Moving on to cord compression. Obviously a complication of cancer. The annual incidence is about 3 to 5 cases per 100 patients a year. Metastatic tumors from any site can cause it, though notably it's most often lung cancer, prostate cancer, myeloma, and breast cancer. Scary is that it's initially sometimes the manifestation of a patient presenting with cancer, and that can happen up to 20% of the time. Only a small proportion of vertebral mets are actually complicated by cord compression. The cardinal features are symptomatic spinal cord or nerve root compression and mechanical instability of the column. Early diagnosis of spinal mets helps prevent the development of neurological deficits and structural instability. I think in today's world, we're much better at picking up on this stuff because we have a better access to scans and whatnot, but 80s, 90s, earlier, times like that, getting MRIs as frequently as we get them didn't happen. So I think we do a much better job today than we did years ago at picking spinal mets up early and treating them rather than waiting too long and waiting for them to develop symptoms. Pain can also be the initial symptom, and it's often prior to the onset of any motor or bladder instability or dysfunction. It most commonly arises in the thoracic spine. Motor findings are actually a late finding. So if you are already seeing someone that you've sat on and you find motor findings, you've missed the boat. Sometimes that's how they present though, and there's nothing we can do about that. But that is why back pain, back issues, back anything should really be looked at as an emergency in cancer patients to prevent cord compression. Sensory findings are much less common than any motor findings. Cauda equina. So this is, I think, something that we've also always been taught that means cord compression. It's compression of lesions in the lumbosacral spine below the level of the conus medullaris. Symptoms often include radiation of pain into one or both legs. Weakness tends to be less severe and asymmetrical with compression in the lumbosacral region as compared to with thoracic lesions. Interesting, and what I want to point out is this is not always associated with cord compression. So I think in textbooks and even when I was in medical school, it was always talked about that Cauda equina, you should treat that and work that up as cord compression. I'm not saying don't do that, but also put in your differential leptomeningeal disease, because they can both present the exact same way and would be treated differently. So step one, cancer patient that has new back pain. What should we do? MRI, whole spine, with and without contrast. Why am I saying whole spine? Because if you can identify where you think this lesion is, and why would we not just MRI them there and forget about everything else? Well, bone mets are rarely limited to a single site, and multiple epidural tumor deposits are present in approximately 1/3 of patients with cord compression. Clinical localization of the lesions is actually pretty imprecise. The compression lesion might actually be several levels higher than what is suspected by a sensory or motor deficit. And this was reviewed, and I didn't put the reference down there, and I apologize for that, so I will get this to you. The importance of imaging of the entire sac. This was illustrated by a retrospective study in about 340 patients. In this report, failure to image the cervical spine in patients with symptomatic thoracic or lumbar epidural lesions would have missed secondary epidural lesions in only 1% of patients. However, failure to image either the thoracic or lumbosacral spine missed lesions in up to 21% of the cases when symptomatic disease was localized elsewhere. So cancer patients, when you're talking about back symptoms, neuro symptoms, get the whole spine. It might not need to be done immediately. So if you're really worried about a thoracic lesion and you know it's going to take forever to get all of them done, do the thoracic one, but keep in the back of your mind in the next day or two, you do need to get the whole spine. Step two, assess the need for steroids. The standard dosing is dexamethasone 4 milligrams Q6. Once you've made the decision that you are concerned for cord compression, this is the dose. It's not lower, it's not higher, it's not Q12, it's not Q8. It is 4 milligrams Q6 hours. And you will get some people that start complaining about the blood sugars and the this and the that, but we can control blood sugars. We can control them. So this is the dose, and there's no other dose to give. Once you pull the trigger to make the decision to treat with steroids, this is what you treat with. Now, a normal exam with a patient with isolated pain, you could consider holding off. I am not sitting here saying that every single patient that comes in with back pain has a history of cancer, you should be worried about this, because that's basically everyone that has cancer is going to complain of back pain at some point. So there is still an element of clinical judgment that needs to be done. But if you're concerned at all, start the steroids. Any new or progressive subjective patient complaints or pain or neuro exam changes should prompt steroids even before the scans are done. Reason being, we can all order stat MRIs, and we all know that they don't happen stat. So I would venture to say, if you're worried, again, start steroids, order the scans. No one would ever blame you for starting steroids if you were absolutely wrong. Step three, don't call us, actually. Don't wait for our recs. If you have radiographic evidence of cord compression, we are not the first people you should be calling. We're not even the second people you should be calling. The first thing you should do is immediately start steroids. The second thing you should do is immediately call neurosurgery. And then after that, call radonc. Those are the things you should do. We actually can't help that much besides just telling you this. And the people you want to involve ASAP are the neurosurgeons and the radiation oncologists. And I say neurosurgery first because they should be the ones first. If something needs to be intervened on in the middle of the night, neurosurgery will do it. There's not a ton of evidence for stat radonc procedures in the middle of the night. They have their own, and one of my friends is a radiation oncologist, so we argue about this, but they have their data that says waiting a day or two from their standpoint doesn't change much. That is not to say that intervening surgically doesn't make a difference. That is a very different story. It does make a difference. So this is an oncologic emergency, but oftentimes it's presenting to you guys before we will even see it. So step one, steroids. Step two, once you're concerned about it and you have radiographic evidence, call neurosurgery. I will warn you, don't call neurosurgery until the scans are done, because they will blow you off. No matter what hospital you're at, always wait till the scans are done and give them a call, okay? This is in your hands. This one you'll see a lot of, and I've seen it a decent amount where people don't start steroids, not just here, but it's just because it's not a common thing. Start steroids. Always start the steroids. So some big take-home points. APL can flip on a dime. Whoever's been on service with me and there's been leukemics on the floor, and I say leukemics meaning AML and APML, though I mostly talked about APML here, they can flip on a dime. They can be walkie, talkie, look fine, young, healthy, joking around, and crash within minutes. It's a real thing. They can become very, very sick very, very quickly. And as I said at the beginning of the talk, the first 24 to 72 hours is very, very important. That is when, especially in APML, if death is going to occur, it happens then. I'm not saying they can't die of neutropenic complications later on, but from the disease itself, it is most dangerous upon diagnosis, right around the treatment time. Treat each of their complaints as serious. So pneumonia in a cancer patient, particularly anyone with marrow involvement, is not the same as pneumonia as a healthy 60-year-old that's in the hospital for COPD. These patients' marrow are not functioning properly. They do not have the same immune system. So a pneumonia that doesn't look that bad, or that they clinically don't look that bad, or whatever other parameters you want to use, erase them from your mind and escalate it about 2 or 3 notches, because they can get and will get more sick than your standard patient. In terms of tumor lysis, fluids, 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 fluids. And the reason I say that is twofold. One, because it really does help control the side effects of this quicker than anything else can. But also, if you wait long enough, this turns into permanent kidney damage. Permanent kidney damage can often preclude patients from getting chemo. So not only is this important in the hospital stay, but if they develop permanent kidney damage from tumor lysis, that could preclude them from getting chemo. And that means it could have been a curable disease or not curable disease, but regardless, you've now, not you, but us as a medical field, have now made it so that they might not be eligible for chemotherapy. So that's the real detriment down the line, is to make sure we're preventing kidney damage. This is just my own little plug. I think CBC without a diff should be eliminated as a test, because I think we miss so much information if we're not looking at the diff. So I would say if you're ordering it and if you're worried about a white count at all, then I think you should get the whole CBC with diff. Any back complaints in a cancer patient should prompt some sort of imaging. And that could even just be an x-ray. If they fell and they have back pain, it's pretty isolated and you can pinpoint it, get an x-ray. But if it's anything more than that, I'd really suggest getting an MRI. And we probably over-order MRIs. I guarantee we do. The problem is you want to catch these spinal tumors before they become a problem. So any back problems, I would venture to say, get the MRI. If there is a concern for cord compression, steroids first, get the imaging. Once confirmed, call neurosurgery, call radonc, and then let us know too. And that's not to prevent us from getting calls in the middle of the night. It's truly that the people that need to be involved urgently are the neurosurgeons. And if there's ever a doubt, please have a smear made and call us. We're always happy to go over it with you. And I don't expect you guys to look at smears and go over them and know what they mean, because it's kind of a lost art. It really is. But if you ever have a question or you want to go through it, we have a great lab tech over there. Her name is Linda, and we always sit down and go through slides at least once a day. So anytime you're concerned, by all means, just let us know and have us get a smear, and we'll look at it together. All of these things that I talked about, there's very few that this means this, right? So that means that it has to be a high index of suspicion. These are all rare things that I'm talking about. So I'm not thinking that this should be number 1, 2, or 3 on your differential on most general medicine patients. But it should be always in the differential, because to miss it is scary and can mean death. And unless you look for it, you're not going to find it in some of these patients. Even though the underlying disease is often very serious, the presentations can be very, very subtle. So it has to be in the back of your mind. It has to be something you're working through in the differential.